Welcome, and thank you for joining us tonight for Henry Ford Allegiance Health's community presentation on preventing colorectal cancer. My name is Jen Anga, and I'm a marketing specialist here at Henry Ford Allegiance Health. And before we get started, I'm just going to go over a couple housekeeping items. So this presentation tonight is going to last for 30 minutes, and then we're going to save 15 minutes at the end for a question and answer session. All participants are going to remain on mute. That's just to prevent any background noise while our panelists are presenting. So if you have any questions that you'd like to ask, we're going to be using the Facebook chat feature to do that. So as questions come up, feel free to just enter those into the Facebook chat. And if you have a question for one of our panelists specifically, just make sure that you mention their name when you're putting that comment in. So now we're going to kick off and we're going to start with some introductions. So Donna, if you would like to introduce yourself.
Good evening. My name is Donna Long. I'm the screening manager for the Henry Ford Cancer Institute. So I coordinate all the cancer screenings across the health system.
Wonderful. Thank you. And Dr. Gupta, if you'd like to introduce yourself.
Hello, I'm Dr. Vishal Gupta. I'm a board-certified gastroenterologist and hepatologist here in Henry Ford Allegiance Health. I've been here for the last 12 years, and I welcome this opportunity to have this discussion.
Wonderful. And last but not least, Dr. Pfeifer, would you like to introduce yourself?
Sure. My name is Chris Pfeifer. I'm one of the general surgeons here in town. I've been here, like Vishal, about 12 years. I did a minimally invasive fellowship out of residency, and I also take on the role of being the program director for the general surgery residency at Henry Ford Allegiance Health. So I too am excited to talk about this important topic and get some information out there for all of you.
Wonderful. Thank you all so much for joining us. And Dr. Pfeifer, we're actually going to start out with you tonight. So can you just tell us how common is colorectal cancer and who does it usually affect?
Sure. Colon cancer is currently the second leading cause of cancer deaths in the United States, unfortunately. The American Cancer Society estimates for the number of colorectal cases for the U.S. in 2021 will be approximately about 104,000 for colon cancer and about 45,000 for rectal cancer. So people's lifetime risk of getting colon cancer is about 1 in 23 people for men, which is about 4.3%, and 1 in 25% or 1 in 25 for 4% for women. There is about a 25% higher chance of men getting colorectal cancer than women. Also, there's about a 20% chance higher in the African American population versus Caucasian. So that's kind of who ends up getting it and how common it is.
Wonderful. Thank you. So, Dr. Gupta, why is screening so important and what can we do to prevent colon cancer?
Truly, this is such a relevant talk to have, and I should have mentioned that previously. This is the Colorectal Cancer Awareness Month, and so hence what an apt discussion to have. But like Dr. Pfeifer mentioned, colorectal cancer is the second leading cause of cancer death in the country. 1 in 20 Americans get colon cancer in some stage of their life. So that's a staggering number. Often and usually, these patients have no symptoms. They come for a routine checkup, which is called a screening colonoscopy, where once the patient is sedated, we insert this fiber optic camera from the rectum into the entire colon, which is around a 6 feet long tubular structure. And the intent of this is to look for polyps. And what is polyps? Polyps are these small growths which are known to be precursor to colon cancer. And hence the goal is to detect these polyps before they grow into cancer of the colon. So in one session, not only are we able to detect these polyps, but we can remove them before they go on to becoming cancer of the colon. And hence, colorectal cancer is preventable. Please not to forget Majority of these patients who have this procedure have no symptoms. They present for a routine checkup, and if you look at them, they look great. I mean, they have no medical conditions or symptoms. And here we are, we remove polyps. And unfortunately, sometimes we even find colorectal cancers. Just to dwell a little bit about colorectal cancer, in early stages, if it's detected, we know that the patient has the best chance of a complete cure of this condition, and they can go on to live a full life. So not only is colorectal cancers preventable, it's treatable, it's beatable, and it's curable. Thank you.
What are the screening options and what's most recommended at this point?
Great question. The number one gold standard for screening is the colonoscopy, because the physician can visualize the entire colon, and as Dr. Gupta explained, if there's any precancerous polyps, those can be removed. There are a few other options out there, some at-home tests, Cologuard or Fit Kit that can also be done, although those are not as accurate as a colonoscopy, and they cannot detect polyps to get those removed. But when it comes to choosing between an at-home test or the colonoscopy, the only bad decision is not to get screened at all.
Gotcha. That's great information too. So Donna, I'm going to stick with you for this next question as well. Should someone wait until COVID-19 is gone, or is it safe to go to the hospital now?
No, definitely don't wait. It is safe to go to the hospital now, and we do recommend you get your preventive screening. We know that about 1/3 of adults have put off screening since the pandemic, and we are starting to see diagnosis at a later stage. The key to screening is when you don't have symptoms, and we're going to catch any precancerous polyps or an early stage cancer when it's most treatable. Henry Ford has taken several safety precautions across the system. We screen everybody that enters our buildings for COVID signs or symptoms. Our staff do thorough cleaning between all the patients. We social distance in waiting areas. Of course, we have our mask and gloves. So it is safe. We have taken lots of safety precautions to keep you and our staff safe, and we highly encourage that you call and get your cancer screening appointments.
Wonderful. So Dr. Gupta, can you share what the prep is for colonoscopy and how long does that prep take?
Sure, another very great question. So please, the prep entails roughly 3 days prior to the procedure. We advise a patient to start a low residue diet, which would mean to eat more of eggs, yogurt, banana, mashed potatoes, and please refrain from having nuts, seeds, salads, corns, as they can interfere in the quality of the preparation that we want. Then subsequently, the day before the day of procedure, the patient starts drinking the clear liquid diet, and they do that for the whole entire day from the date of the procedure. And what we mean by clear liquid diet is we mean apple juice, ginger ale, jello, and please even popsicles and clear broth soup can be considered. In the evening prior to the day of procedure, the patient drinks this laxative, half of which is drank in the evening prior to the day of procedure with the intent of cleaning the colon of the solid stool. But please remember, the colon continues to secrete juices into its own lumen, and that needs to be rinsed. And for that reason, the morning of the procedure and is up to 4 hours prior to the time of the procedure, the patient drinks this second half of their bowel prep. And the relevance of that also resides that a good quality prep is the single best indicator in a thorough examination and an accurate, high quality procedure.
And this question is for you again as well. So what options do you have for someone who's very hesitant about getting a colonoscopy?
So please, I think the way I see it is patients, I mean, colonoscopy is somewhat of an awkward procedure to say the least. The thought sometimes can be somewhat repulsive, but quite frankly, most of what surrounds people's hesitancy resides in the myths and misinformation that there is out there still in the community, to which people have heard anecdotally at times. And really, we want to dispel that fear if that's what it is. And not only we want to allay that fear, we want to ensure that the patient is comfortable in undergoing this procedure. And I think the single best way to address this hesitancy and concern is by the patient should seek out discussions with their primary care physician or endoscopist, such as Dr. Pfeifer and myself. And we love to sit with our patients to talk about what the colonoscopy entails, which is essentially that the patient please presents for the procedure. They are asleep during the entire duration of the procedure. And once they're sleeping, we go in with this camera, which is a very delicate fiber optic scope. And again, we look for those precancerous lesions, and we can essentially remove them and save a life. So as much as is the myths and misinformation there is, afterwards, post-procedure, the peace of mind that the patient obtains is considerable. I think it's worth the effort that a patient may have to undertake to be prepared for a colonoscopy. It's a very safe procedure, and it can be a life-saving procedure. So please, again, a great patient-doctor relationship is key to a guaranteed colonoscopic examination, and most often and more likely, patients always opt for the gold standard colonoscopy as their choice of screening test.
Not something that people should be scared about and nervous about. Just talk to you and you'll give us all the facts on why that is the best route. That's great. Thank you.
Thank you.
Dr. Pfeifer, does having colon cancer necessarily mean that someone is going to have a colostomy bag?
No, our technology has advanced a lot in even the last, 10, 15 years. Before, when you had colon surgery, we used to have to do an open procedure. We used to have to make a larger incision on the middle of your abdomen, about 6 to 8 inches long. And we'd have to go in, resect the part of the colon, and then put everything back together. And a lot of times the recovery from that was you'd be in the hospital 5 to 7 days. You may have a tube in your nose, and those type of things. And it just, nowadays, we can do a lot better than that. We have minimally invasive techniques where we can do either laparoscopic or robotic, where we're making just little incisions, 4 little incisions, the biggest no longer than an inch, where we go in, put our ports in, we're able to see so much better. We're able to resect with better precision the portion of colon that needs to come out. We also have, with the robot, it's less pain, it's quicker recovery, all of these reasons because of the little incisions. We also do abdominal blocks. Anesthesia helps us and puts abdominal blocks in the patient's abdomen prior to surgery, because if we can stop pain before we even make the incisions, people are going to do better. They're going to have faster return of bowel function. Also, a lot of times the urologists help us because the ureters or the urine tubes run right by the colon where we're resecting. And sometimes it's good to kind of have a little guidance to where those are so we can keep the ureters safe during our operation. And a lot of times the urologist will come in and inject some dye into those ureters for us, because on the robot we actually have what we call Firefly technology, where we flip a little laser on and it helps light that up so we can actually see those ureters. So again, just better things to keep people safe. When we put the colon back together, because it is a long tube, it's kind of like plumbing. If you take something apart, you have to put it back together, and it has to be leak proof. And we test for all of that. The chances of an anastomotic leak, that's a fancy doctor word for putting it back together, is less than 5% these days. That's pretty good. And the only time we really have to do a colostomy is if we can't get things back together and it's too low in the pelvis, or it's leaking, or there would be a danger of non-healing. Sometimes we have to put the colostomy bag up. And most of the time, unless it's for a really low rectal tumor where we just can't get the margin that we need in order to do a safe oncologic resection, in other words, to get rid of the entire cancer, we sometimes have to do a permanent colostomy, but that is very rare. Most of the time, they are temporary colostomies where we take it down in about 8 to 12 weeks afterwards. So again, an inconvenience. Nobody likes to have a colostomy bag, but it is something that people can live with and that we can fix. But the only other time too that sometimes a colostomy is needed is if people have late stage cancers that we don't pick up on colonoscopy, unless there's a problem and it's perforated or it's obstructed and we just can't safely put things back together. Sometimes we have to do the operation in stages where we get rid of the cancer, do the colostomy, let everything heal, and then bring things back together. So again, this highlights what Dr. Gupta has been saying is the real reason for prevention is if we can get it at the smaller stages, if we can get it at the stage 1 before it even turns into a problem, that is sometimes you don't even need me. You can just get the small polyps or the small tumors out endoscopically with an endomucosal lift procedure and other procedures to try and get this out before we can even have to do surgery. So most of the time, unfortunately, when it is cancer, you do need to see the surgeon to get it removed because that's the only way to completely get rid of the cancer. But that's what we can offer from a surgical perspective to help cure this disease.
Wonderful. Thank you for that detailed explanation. That's really helpful to know and hopefully put some people at ease a little bit there too. Dr. Gupta, besides screening, what can we do to prevent colon cancer?
So great. And this is such a relevant question again. Please, so far we have talked about preventing colon cancer. But what I try to focus with my patients is how can we prevent a polyp from forming? So they never have a polyp, so of course then they'll never have a colon cancer. And for that, a well-balanced, healthy lifestyle is really the easiest and the best way of preventing a polyp from forming in the first place. And what we mean by that is, please, like what we see on television, what our doctors tell us, what our community leaders even tell us at times is eating fruits, vegetables, avoiding red meat, that's a big one, as also processed meats, that have been shown to lead to colorectal cancers. So that should be refrained from. Please to eat more white meat. Again, smoking and alcohol have been linked to patients developing colon polyp and in future even colon cancer. Additionally, sedentary lifestyle has been shown to again lead to colorectal cancers. So hence we recommend that the patient should exercise for half an hour, 5 days a week. This is almost common knowledge now and has been shown and proven to lead to a decreased risk of colon polyp formation. Additionally, there have been studies which have shown calcium, vitamin D, as also a low-dose aspirin can decrease the risk of colorectal polyp formation and or cancer formation. However, we don't recommend these supplements as a blanket policy, but do address them on a case-to-case basis. And I would encourage my patients to please reach out to your primary care physicians and or Dr. Pfeifer or endoscopists such as myself as well, where we can guide you which may be the right one for you. But again, prevention is better than cure, and this is what we are focusing on today.
Wonderful. Thank you so much. So we all have some tips and things that we can take home and start doing to help prevent this. So that kind of wraps up the questions that we had. So now we're going to go to some of the comments and see what types of questions we've got from our audience. So I would like to ask, does colorectal cancer only affect people over 50? I don't know if Dr. Pfeifer or Gupta, one of you would like to address that question?
I think we both can address the question because longitudinally, Dr. Pfeifer and myself work together. So I would like both of us to answer this question. But from a gastroenterologist such as myself's point of view, yes, we are seeing more and more patients having advanced polyps and or colorectal cancers at an earlier age. And for that very reason, initially the American Cancer Society in 2018 recommended that colonoscopies or screening tests should be performed at age 45. Then United States Preventive Task Force stated the same in 2020. And earlier, in fact, in February of this year, the American College of Gastroenterology recommended the same, that we should screen everyone at age 45 and not 50. Unfortunately, still there are patients who are diagnosed with colorectal cancers at a younger age. And Chris, you may want to add more to the story.
Sure. I think the main thing is what we're talking about. Colorectal cancer, unfortunately, is a very silent disease. You normally don't pick things up very quickly. So it's important to remember that there is a family history to colorectal cancer. So you should have kind of a more awareness if a first degree relative like your mom or your dad or your brother or sister has had a history of colorectal cancer. You should pay attention to that and kind of the age at which they had the cancer, because if they had the cancer very early, there are sometimes some syndromes and some polyp syndromes, such as familial adenomas, polyposis syndrome, and things like that, that can cause, or if a history of ulcerative colitis and these types of diseases. It's just good to know about them, because if you have them, you should make sure you tell your primary care physician so that we can, pay attention and kind of get people with these higher risk problems maybe to the endoscopist a little quicker. And the other thing I would also say too is don't ignore the little symptoms. What I mean by that is if you have blood with your stool looks black, or your stool isn't the same caliber, a lot of people like to write it off, or that's just something I ate, or that it's nothing, it's just hemorrhoids, it'll be fine. It's one of those things where those things can be one-offs, or they can kind of be isolated incidents, but it should definitely get your attention, and you should at least bring it to your doctor's attention so that they can kind of make a risk profile and kind of figure out like, hey, maybe you should have a colonoscopy and get that done sooner. So just don't ignore the little symptoms, I guess is what I would say, because it is happening to people under 50, and we're definitely seeing it in the community.
Great, thank you. So we just got a question, and can either of you speak to any of the statistics on diverticulitis patients and how common it is for them to develop colon cancer?
Again, I think Chris and we both can talk about it, because we are in such strong partnership for the care of our patients that I think these questions are relevant to all of us. From our point of view, diverticulitis is a condition where there are pockets in the lining of the colon. We see it more often in the Western diet, which includes more processed food. It's typically on the left side of the colon. And so what happens really is, over time, people develop these small pockets in the colon, and these pockets grow in size. And eventually, just sometimes, they can get infected. And that is what diverticulitis is. While diverticulosis is just a pocket, its infection is diverticulitis. That really does not increase the risk of colorectal cancers. However, there are many studies, in fact, which have shown that patients who have diverticulitis can also have colon cancer, or colon cancer can present itself with symptoms which otherwise would suggest that the person has actually diverticulitis. And for that very reason, a colonoscopy is indicated after 4 to 6 weeks after an attack of diverticulitis to make sure that they do not have colorectal cancers. And age is not a factor. So even if it's a 30-year-old with diverticulitis, they should also undergo a colonoscopy. But Chris, I would like you to add to this story, please.
Yeah, no, I agree with what you're saying. diverticulitis can cause inflammation of the colon, but it doesn't really increase the colon cancer risk. Again, when you have diverticulitis, you normally end up seeing both the gastroenterologist and the general surgeon because we treat the disease from different aspects. But most of the time, like Dr. Gupta said, you will get a colonoscopy about 6 weeks or so after a bout of diverticulitis if you haven't had one, just to make sure that we're not missing any colon cancer, because sometimes those symptoms can be mimicked. So.
Thank you. So another question from one of our viewers: are patients with lifelong Crohn's disease more likely to develop colon cancer?
Yes. So please. So again, there's a main medical condition called inflammatory bowel disease, and within it there are two subsets. One is Crohn's disease, and its a very close cousin is ulcerative colitis. And both these conditions increase the risk of future colon cancer in these patients. And for that very reason, 6 to 8 years after the diagnosis of Crohn's disease, these patients are advised to undergo a colonoscopy every 1 to 2 years for an infinite time, as they are at increased risk for colon cancer. So not only to check for so I'm assuming that this patient has Crohn's disease, the person who asked this question, but please note that Crohn's disease itself, its disease activity can wax and wane, and a colonoscopy is really the single best tool to examine the colon to make sure that even despite the patient feeling otherwise well, their condition may still not be dormant, and hence we must examine the colon for that reason, as also to make sure that they are not developing these precancerous lesions, which again, they are more patients with Crohn's disease or ulcerative colitis are more susceptible to.
Wonderful. And so we've got one more question here. How long after a colon resection should someone have a colonoscopy done?
So that's a good question. It kind of matters on the reason for the colon resection of why you're having it. Sometimes we'll have to go in for perforated diverticulitis, and we, take out that section of colon, and then before we may have to do a colostomy, and then before we put you back together, sometimes we like to have the colonoscopy so we can make sure there aren't any other lesions or any other problems. But normally after surgery, we normally like to wait at least about 6 weeks to let everything kind of heal up, especially if we put things back together with an anastomosis or a connection with the colon. We want to make sure that that's good and strong and healthy before, because when we do a colonoscopy, in order to see, the tube is kind of collapsed. We have to put air into the colon so that we can see the wall and visualize everything, because the whole point of doing the colonoscopy is to see the whole wall and make sure that there isn't any polyps or any problems. So sometimes when you're putting a little bit of pressure on that anastomosis, that makes the surgeon a little worried. So we like to have that done after it's a little healed, and we don't have to have so much worry. So.
Great. Thank you for that answer. Let's see. Are there any signs if someone has a polyp? Is there something that we can look for that?
Chris, thank you.
So unfortunately, a polyp is silent. It's only seen in the colon wall and in the colon lumen. So unfortunately, unless it's causing symptoms where it's large enough that it's blocking or causing an obstructive symptom, polyps don't really cause pain. The only thing they can kind of do is get big enough to block things off. And that takes a long time to get a colon polyp that big. So unfortunately, the only kind of way to see polyps is a direct visualization via colonoscopy.
Gotcha. Here's another question about prep. So this will probably go to Dr. Gupta. Are there different options for colonoscopy prep? Can certain types work better for certain people?
Please. So there are different kind of preps, and we tailor the preps dependent upon the patient. So for example, if they have a heart condition, or if they have a kidney condition for that matter, and or even their age, we factor that into recommending what sort of prep to take. So what I'm trying to suggest is, please, there are higher volume preps and there are smaller volume preps. There are preps which have different ingredients in them, and hence they work somewhat differently. So it's pretty complicated, but our intent and goal is really to cater to the medical needs of the patient and also the patient's own desires. And hence there are choices, and you just really need to reach out to us and tell us about your preferences. And there is no blanket policies. There is no single prep only. There are higher volumes, lower volume preps, which work almost equally well. So please reach out to your gastroenterologist or endoscopist to ask these relevant questions, and we'll be happy to answer them.
Great. And one thing that I remember a couple years ago, there were quite a few commercials for Cologuard. Can you talk a little bit about those, or a little bit about that product and who might qualify for using that?
Sure. So Cologuard is a stool study, and it's really dependent on the DNA of a cancer that may have somehow been secreted into the stool, and it can detect that DNA. So that's the whole basis of the Cologuard test. Initially, it did get the attention it deserved, and what we did see is that it's somewhat, to a great degree, very accurate to diagnose colorectal cancers. But unfortunately, we don't only want to detect colorectal cancers, we want to actually prevent colorectal cancers by detecting colon polyps and removing them. Cologuard, unfortunately, does not offer that relevant knowledge or information that we are seeking. So the right candidate for Cologuard may include someone who is advanced age, so maybe someone who's 90 years of age, someone who has had multiple strokes, or had heart condition which limits them from getting a colonoscopy. So if they are not candidates of a colonoscopy, then of course, the thought process is something is better than nothing. But so for those subset of patients, we do recommend Cologuard. But just this month, in fact, earlier this month, United States Preventive Task Force also came up with recommending that Cologuard should be the second-tier screening test and should not be the test of choice for screening for colon cancer.
Right. The other thing I'd like to add about Cologuard is you're kind of detecting it when it's too late. You already have cancer. That's the whole point of what the Cologuard is trying to find. So the whole point of colorectal disease prevention is to get it before it gets to that stage. So I agree with Dr. Gupta. It's used in some subset of patients, but this is definitely not a first line. Like, because some people are like, if I can get this, maybe I don't have to do the colonoscopy. That's not what this is there for, or what it was ever intended for. So it's like anything, you want to have other options for other situations if you need it. But this, unfortunately, is not the panacea to get anybody out of a colonoscopy.
And just to add to that, only it's interesting. It's funny, only coincidentally, today I had a patient who had a Cologuard test which was positive. So we performed his procedure. So imagine he had a positive test. For the last 5 weeks, he's been anxious. In his mind, he thinks he probably has colorectal cancers. As it turns out, his Cologuard was falsely positive, meaning the test was positive, but there was nothing in his colon at all. So for the last 5 weeks, he's been anxious about it. And then still, if it's positive, you have to undergo a colonoscopy. On the flip side, there are these patients who actually have conditions such as polyps in them, and the test can come back as normal, and then the person can have this false sense of security that they don't have anything in them, when indeed there is a polyp, which if removed now, can prevent that future cancer from forming. So that's why we don't support Cologuard as much.
That's such great information, and I know that's been a hot topic for a number of years, and I just appreciate the candid responses there. Donna, I have a question for you. Does someone need a referral from their primary care provider to have a colonoscopy done?
It really depends on your insurance. Most insurances will let you have preventive services direct access, but you'd always want to check with your insurance and have those conversations with your primary care physician about when screening is appropriate for you. Because like we mentioned, the American Cancer Society and U.S. Preventive Task Force has decreased the age to 45. Unless you have a family history, you want to have an individual conversation about when screening should begin for you.
That's great. That was just my next question. Is there any reason for someone who's under 45 to have a colonoscopy done?
Certainly if they're symptomatic, like we said, a persistent change in bowel habits, rectal bleeding, abdominal pain or discomfort, or if you have a family history, your mom, your dad, brother, sister, maybe even your grandparents, have that conversation with your physician about when and what is the appropriate test for you.
Great. Well, let's see. Another question, and we kind of touched on this a little bit, but I think it's an important point too. How fast does this cancer spread? And Dr. Gupta, is there a cure?
So, in fact, I would like to have Chris answer most of this question, but I'll start off. But or why don't you start off, Chris? I think that's a very relevant question for you.
So, a lot of times colon cancer kind of starts, as we've been talking about, with polyps. So there's something called the adenoma to carcinoma sequence, a fancy kind of sequence of it starts as a polyp. There's a couple problems with the DNA mismatch and where the off switch gets goofed up, and instead of becoming a small little polyp, it turns into a cancer. The reason we do colonoscopies every 10 years is it normally is a very slow process. It normally takes 5 to 10 years to get from a polyp to a cancer. So once you get a cancer, what we worry about is it going to spread to the lymph nodes? The lymph nodes are in the fat tissue that kind of hangs off the colon, and those are kind of the signs. If it does get to those lymph nodes first, then we worry that it possibly could get elsewhere to liver, lung, brain, other places like that. So the faster we find the colon cancer or the rectal cancer, the better people are. You do better if it's in a lower stage. If it hasn't gone to the lymph nodes, then sometimes just doing a colorectal resection where a surgeon just takes out the colon and puts it back together, there's no other chemotherapy or radiation needed. It's just surgery and it's a cure. If it gets to the lymph nodes, a lot of times we have to ask our oncology colleagues to help us with adjuvant chemotherapy. And sometimes with rectal cancer, we have to even do the radiation and the chemotherapy before we do surgery to shrink the tumor, to allow us as surgeons to get better margins, to allow us to give you a better chance at curative disease. So is colorectal cancer curative? Yes. Is it better to catch it early? Yes. If we get to stage 4 when it's gone to other organs, it makes it a little harder to completely cure the disease. So.
Thank you so much, Dr. Pfeifer. And it looks like we've got time for just one more question. Are there any correlations between colon cancer and other cancers?
Absolutely. So there's a strong propensity, which is genetic in origin, of which we are still studying. The geneticists and the molecular biologists in this country are actively studying it, and newer information is coming out on a very regular basis. But indeed, in patients who have, say, familial adenomatous polyposis syndrome, or FAP as is known as, these patients have an increased risk of, for example, uterine cancers, stomach cancers, even liver cancer. Similarly, breast cancer and colon cancer has been shown to be or related to a single gene mutation. And more information has been obtained about other cancers being associated with colorectal cancers. And please, the finesse of this is you have to understand that it's all genetics in the end to a great degree, whether it's lifestyle or good lifestyle or not so good lifestyle. That is, in a way, it protects us from getting colorectal cancers. But some people are more predisposed to others, and that likely is from genetic in origin, of which we are learning more about. So yes, please, anyone who has had even a prostate cancer, breast cancer, any cancer for that matter, I think they should be very fine-tuned into looking for any blood in the stool, looking for any change in bowel habits, any weight loss, or any subtle abdominal pain-like syndrome or symptoms. And there could be markers or indicators of a possible colonic malignancy or colon cancer. So please keep that in mind.
Well, thank you so much, Dr. Gupta, Dr. Pfeifer, and Donna for joining us tonight and sharing your expertise on this topic. It's not an easy conversation to have, and so I think, and hopefully this made the forum a little bit easier to get some of our questions asked and answered. And again, thank you to everyone who tuned in this evening. We really appreciate your feedback, and as I mentioned, that this is a difficult topic to talk about at times. So if you still have questions and something that you want to know did not get answered, feel free to send a message to our Facebook page, and we can always send that to the doctors and connect with you offline. And again, I just want to thank you all for presenting this evening and joining us. So thank you.
No problem.
Thank you. Thanks.
Thanks a lot.
Have a wonderful evening.